My name is Alyssa McCrae. This is my daughter Annika and my mother Lois.
I was first diagnosed in 1989 and was fine for 19, almost 20 years. And then I was diagnosed with breast cancer in the other breast. The surgeon recommended that I be tested for a genetic marker. When the results came back that I did have the BRCA1 mutation, it was explained to me that that meant my daughter would have a 50-50 chance of also carrying that same genetic mutation.
I found a genetic counselor at Georgetown and met with her to review my family history of cancer, as well as to have the blood work done that would show whether or not I had the gene. And my test result came back positive for having the BRCA1 mutation, just like my mother.
They had to get tested to make sure that they had the gene in them, and then they had to decide whether or not they wanted to get it out, because it might not, there's like a small chance that it wouldn't do anything to them.
So I ended up sitting on that for a little while. The turning point in my decision-making process was talking with a woman in my office building who had gone through treatment for breast cancer and had a long family history of the BRCA gene mutation and didn't realize it before she had gotten cancer, and she said she would do anything to avoid having to go through chemo. And then I thought about both my mother and father having gone through chemo and various cancer treatments my entire life, and I thought, well, why wouldn't I want to avoid that?
She did a great job because she interviewed multiple doctors before she made a decision about her surgeons and who was going to treat her. But she could do that because she knew ahead of time and she did not have cancer.
When Alyssa first came to see me, she had just been told that she was a BRCA1 gene mutation carrier. Of course, she had a family history, especially in her mother, who had both breast and ovarian. And at that point, Alyssa did not have any diagnosis of breast cancer, which is exactly the right time for somebody to come in once they found out that they're a gene mutation carrier, because at that point, they have all the options available to them. So the discussion that I have with any patient in that scenario is to discuss the option of having surgery or not, because surveillance is certainly an option. So we had what would be a typical consultation around having risk-reducing mastectomies, what that would entail, and then I will refer them on to a plastic surgeon. After they've met with the plastic surgeon, we refine the operative approach.
A couple of weeks before I had the surgery, that the plastic surgeon said to me that he had spoken with Dr. Willie, and they discussed that because my breasts were so small that it seemed reasonable to do the nipple-sparing surgery, that I'd have a good chance at saving the nipples.
I guess I was a little bit nervous, like, well, there's still tissue there. What does that mean?
It's interesting women's reaction when I talk with them about nipple-sparing mastectomy, because there are some women who know about it and have decided they don't want it, because they're worried about whether it's safe or not. And that's where my job comes in, to educate them about whether they're a candidate or not. There's some women who come in and want nipple-sparing mastectomy, and they're actually not a candidate, either because they have cancer that's too close to the nipple, or perhaps their body shape and size or their breast shape and size isn't perfect for it. Alyssa was the perfect candidate. Her body was the perfect body type and body shape to have the inframammary approach, which is the hidden scar. When you look at somebody face on, you won't be able to see that scar. And it has to do with how heavy she is, with how big her breasts are, with how much ptosis there is or how much sag there is to the breast. And her body was perfect for nipple-sparing mastectomy through an inframammary incision. The nipple-sparing approach allows the patient to have an option that really preserves the appearance of their breasts. In many ways, I think it allows them to accept risk-reducing surgery because the reconstruction and the surgery is so much better than it used to be.
I would say that if I had the opportunity to do it again, I would have opted for the nipple-saving surgery. I had 2 very large scars. By the standards of that day, everyone thought the scars looked wonderful, but that was many years ago.
When I go to see patients on postoperative day 1, one of the happiest things for me is when the patient looks down and says, "It looks like me. It looks so much better than I thought it was going to look at this stage of the game." And of course, we know it's going to get better as we get farther out from the operation.
My chest looks a lot nicer now than it did before I had the surgery. I mean, I was able to take advantage not only of the nipple sparing surgery, but went from an A cup to a C cup. I had, great doctors, both my breast surgeon and the plastic surgeon, who did tremendous work, and I think they're proud of what they did too. I'm very happy with it. Not only do I not have to look at scars that are, make me feel embarrassed in any way, but I know that my husband can look at me and not even notice that I'd even had surgery. I almost don't know what I have because I never had the other. I was able to take advantage of the nipple sparing surgery. And maybe by the time Annika's grown, she won't even have to deal with this. Maybe they'll find a cure for cancer or better treatments that will make it easier to deal with.
Yes.
So, I would certainly hope that comes sooner rather than later.
The second cancer, when I was bald, used to rub my head for good luck.
Really?
You don't remember saying, please put your hat on. I don't like seeing you bald.
Oh, yeah.
Yes.
You can say that.